Well, guys, I am sorry for that delay. Despite my best efforts, technology was still able to let me down when I most needed it to. I'm Eric Roddy. I'm a fourth year neurology resident. I'll be starting my fellowship in Parkinson's disease and movement disorders at Duke University this upcoming fall. And so today I thought we could talk a little bit about a subject that I know we've all seen. Um, we know how to treat, but maybe not always handle very well. And it's not as exciting, I think, is from a research standpoint in terms of breakthroughs, but it's something that's important and I think worth discussing because the way you approach this problem will have a huge influence on how a patient does successfully when they leave your care. So I wanted to ask you guys, does anybody know what we're looking at here on the right of the screen? It is a functional MRI. And so between believe there are 10 of these sequences. The top left is what they call the default mode network. So this is just kind of how your brain is at resting state. And the other pictures that we see here are your brain during different states of activation, task-specific things. So I thought that we could start this off with a video, as all good presentations by movement disorder specialists do. So some of you might have seen this before.
She's the beautiful cheerleader whose heartbreaking story is shocking the nation. 25-year-old Desiree Jennings showed me how she can't walk without twisting, jerky movements. But she walks backwards normally. Doctors say she has a rare 1 in a million neurological disorder that was triggered 10 days after she got a seasonal flu shot.
Started with me not being able to eat without passing out.
You couldn't eat without passing out. I visited Desiree and her husband Brendan at their home in Ashburn, Virginia, to see what their daily life is like. She has to go up and down stairs backwards because something as simple as walking forward can be dangerous. And here's the unusual part about the disorder. Take a look at this. Desiree can run just fine. It's only when she stops. You see, that's where the spasms start. Now you can walk backwards though, and it'll make it better, right?
Yeah.
She runs with a normal stride, and as I ran with her, she even spoke normally. And now you can talk.
Yeah, it's weird. It fixes as soon as I start running.
I mean, you sound
I know, it's grand.
amazing. And then you stop, and that's what happens. Desiree got a flu shot on August 23rd. 10 days later, she came down with what doctors have diagnosed as dystonia, a rare neurological disorder. Her jerking and twisting are the result of uncontrollable muscle contractions. There is no known cure. Are you all ready?
Yes.
This is home video of Desiree as a beautiful bride when she married Brendan 2 years ago. And this is a photo when she was training to be a cheerleader for the Washington Redskins. Doctors say what happened to Desiree should discourage people from getting flu shots. But here's what the woman who's on the wrong side of being 1 in a million says. Running has to be a relief.
The only thing I have left.
The only thing you have left.
So where is the stroke? Or what is happening here? Yeah, this is FND, and I think this is, an extreme example of this, but there are a lot of good examples of some principles that can guide how you approach this patient, what you can pick up on. And there are a lot of demonstrations of some of the non-physiologic ways that functional neurological patients can present. So we'll continue, and we'll talk a little bit about her more as we kind of go on, because her case demonstrates a lot of valuable things. So our learning objectives today, I'd like for you all to be able to define FND within the biological and conceptual framework that we have. I'd like everybody to feel at least somewhat comfortable with identifying signs that are specific to functional neurological disorder. I think that it's important to have at least an awareness of how functional neurological disorder is described in terms of diagnostic criteria, particularly with the DSM-5. And then I think as we go through some of this, we'll emphasize why what we're seeing is not consistent with a physiological state of being or a neurological process that we can localize or explain in a way that doesn't involve functional neurological disorder. Okay. So FND really at its core, it involves neurological symptoms that are inconsistent with or unexplained by a structural neurological disease. Um, this arises from abnormal central nervous system processing, not from structural damage. And the diagnosis now is made on the basis of positive clinical signs. Whereas prior to 2013, this diagnosis was made as a diagnosis of exclusion, which, as we'll talk about later, actually can be a detriment to a patient in many ways. And I really want to emphasize while we talk about this, that it's not voluntary. I think that there are a bunch of terms that we kind of group in with functional neurological disorder, and I think it's a good idea to try to attempt to discern those as much as possible. In not all cases will you be able to do that, but there are differentiating factors between things like functional neurological disorder, factitious illness disorder, malingering, somatic symptom disorder, but they bleed over into each other. At least sometimes it seems so. So we'll go over why those things are different. I think it is interesting also to think about how we've thought about this. It's as old of a disease as we have, dating back to 400 BC. We start with this very sexist theory about the wandering uterus, this idea that hysteria was the result of a migration of a sexual organ. And this carried over for a really long time, and hysteria stuck around as a term that we continued to use. If you look here at this slide, this picture, does anybody know who this is? That's a good guess. Very good. And so this is a famous picture because he would have these lectures on Tuesday where he'd bring in patients and there were a lot of theatrics involved. What do you guys think about bringing a hysteric patient into a room like this and interviewing them? Right. There is at least some degree of variability, probably through suggestibility in functional neurological disorder, but certainly with factitious illness disorder by being witnessed. And it wasn't until really kind of the 90s and early to mid 2010s that we started to think about this in less of a psychologically dependent way and more so in a pure function of the brain way. And this was reflected by the removal of psychiatric illness as a diagnostic criteria in the DSM, which we'll talk about momentarily. So I think people sometimes have the impression that functional neurological disorder is rare. It's not. It actually, in one study, was shown to be the second most common reason for referral to a neurology clinic, which I think that to some of us that are in clinic, this feels pretty true. Sometimes it feels like even more of this. And you do have patients that come in with a legitimate neurological problem with some sort of superimposition of a functional process. Um, I think it is important to note here that these people do have organic neurological illnesses oftentimes as well. The example here being PNES and epilepsy that coexist to each other. But one of the things I think that gives these patients poor outcomes is it takes a long time for them to get this diagnosis, and it costs us a lot in terms of both actual dollars and healthcare resources. The workup that we put in for these patients usually consists of at least an MRI, if not more. They're ordered stat. We treat this emergently, and so it does run up quite a cost to us. We'll talk a little bit about demographics. It does seem that functional neurological disorders is more common in females, but an interesting thing about this is that this gender, I guess, predisposition that we see is really only true for like the meat periods of life. It's been shown that at the early periods and kind of in old age that that gender gap in functional neurological disorder closes up, and so the incidence becomes a little bit more similar. Um, it's been compared to MS and Parkinson's in terms of its disability burden. Like we know, there's not anything structural here that's causing this, but a fair amount of these people end up going on disability or at least eke it out within a year of diagnosis, um, or can't work at that point. It doesn't seem to affect any one socioeconomic class in particular, but those that do have risk factors for F&D that might be a byproduct of the living situation might have a greater risk. So here is an important slide, and I think the most important part about this is criterion B. This is the updated DSM-5 diagnostic criteria of functional neurological disorder, the most recent one we have, which changed the way we thought of it from a diagnosis of exclusion to one that we can rule in. You don't need to have a psychiatric history, as you can see from this, to make this diagnosis, which is helpful in a lot of ways. I think it takes the burden of pressure off of us as providers to prove that there's something psychiatrically wrong with the patient. One might argue that it's a little bit quick to assume that there is, but sometimes it takes trust building with the patient for them to disclose that to you. But this is good because if we can base this on a rule-in diagnosis, we save a lot of time and trouble for the patient. I mean, just think about logistically what this is like. You've got somebody who might be having the first real medical emergency they perceive in their life. And so they go to the ED and they think something really, really wrong is happening, and it feels that way to them. And maybe they get some attention quickly, but then once we feel reassured that there's nothing life-threatening going on, they get shuffled off to like some room in the ED and it's loud and they're there for 6 hours and they just keep getting heard that we need to have more tests. And so if we didn't have this criteria that enabled us to make this diagnosis on a rule-in basis, imagine being that patient that's sitting there in the hospital for 5 days and all they keep hearing is you on rounds. Well, we've got some results and it could be this, it could be that. It's not really coming back consistent with anything that we know right now, which is sometimes how we dance around the idea that they have functional neurological disorder because we're uncomfortable saying that. And so what happens while they're there is they ruminate on this. They start to think, my gosh, I must have something really, really rare or something really, really confusing. Why can't they figure out what's wrong with me? And so then at the end of that, after they've not seen you very much and you haven't had a whole lot of information for them, you say, actually, it's probably just because you were too stressed out. Not a very satisfying thing to hear. And so I think that the timeliness of this diagnosis is important, and the change in the way that we approach the diagnosis has enabled us to make that diagnosis faster. This is just to point out slight differences in like the ICD-11 diagnostic criteria. But this is a little bit different from the DSM in terms of where it is used. So DSM is pretty specific to the United States, and the ICD-11 is used for billing purposes. But the difference here is that the DSM lumps FND into a somatic symptom disorder, whereas ICD-11 categorizes it as a dissociative process. You could make some theoretical arguments about that, but I will leave that to our colleagues in psychiatry. So I think that it would be a good time now to talk a little bit about some of the positive signs that we can see in functional neurological disorder. I don't think that we're going to get through all of them because there's a lot, and at least a couple I'd like to have you guys try while you sit here on yourselves to understand what you should find. But I will say that as you find these, the diagnostic certainty goes up higher than one would expect. It approaches specificity as high as 96 in some situations. But also, because of this, it's important that we document this in a chart. And I'll say that and also preface it by saying, I would like everybody to be familiar with the maneuvers we use to explore this diagnosis. But unless you feel really confident in these or have seen somebody do it, I wouldn't just go and put that they have a positive sign unless you're really, really sure about it, because that's consequential. But some of the principles that we'll see, so variability, this means that a patient's symptom, it just changes, right? So if you think about something like tremor, you think about a fixed frequency, and there's not really a tremor etiology that we see often that would give you a differing frequency. And so that can be a red flag of a functional neurological disorder if you come across it. So incongruence, somebody who has flaccidity, but you get up and see them have a normal arm swing. One thing I like to look for sometimes in room 9 that can be very helpful is like what a patient's feet are doing. So the resting tone of us all who have normal strength in our legs, there should be maybe a slight eversion of our feet when we're lying on our back, but when we have true weakness, you'll see a more extreme eversion of the left leg. So if you go down there and you hear that somebody has acute flaccid left leg paralysis and there's no real eversion while they're lying on the bed, I think that that's something you could call incongruent with expectations. And entrainment, this is one that's really useful when we start to talk about functional motor disorders, specifically tremor. The principle here is that if somebody comes in with a tremor and you ask them to do a rhythmic task with the alternative hand, it's very difficult to maintain 2 frequencies like that. And we actually have some video examples that we'll go through. So some of my favorite things about neurology involve our way to detect how something might be functional. And so I'd like, at this point, for everybody, if you could, take your hands and just kind of cup them under the back of your leg, like you're sitting there. Um, I want you to imagine that you come into the hospital and you say you can't move your left leg, and somebody asks you to lift it up. Uh, just kind of fake like you're straining to get that up, and I want you to really pay attention to how your right hand feels under your right leg. What you should feel as you try to flex your hip is a contralateral extension. This is natural, it's automatic, and it's really, as far as I know, pretty impossible to suppress. So if you have somebody that comes in with asymmetric leg weakness, what you'll do is you'll take your hands, you'll put them under their heels. I usually ask them to lift the good leg first because I can right off the bat establish that there is at least some preserved strength with hip extension in the stated affected leg. You would then ask them to raise the unaffected leg, and in a positive Hoover sign, you would feel no effort to raise that. And so this is what a positive sign would be. Hip abductor sign is a little bit more difficult to explain. There's different ways to do this. Essentially, it relies on the inability to abduct the unaffected hip without at least some degree of abduction of the contralateral or stated affected like limb. Give way weakness. This should be taken with a grain of salt. You can sometimes see this like in the setting of pain, and these can be hard to differentiate. What this is somebody who can demonstrate to you 5 out of 5 strength that just suddenly vanishes, but is easily reobtained. This is just a diagram of the Hoover sign. This one actually is a way I don't ask a patient ever to push their leg into the bed, but this is just kind of the gist of how you would position yourself. So functional tremor and movement disorders. When we talk about entrainment, like I said, we ask the patient to tap a rhythmic beat with an unaffected hand at a set frequency. And if the tremor in the affected hand changes to match that frequency, that doesn't really happen with organic tremor, which is driven by our autonomous oscillatory circuits that we don't have conscious access to. Fixed dystonia at rest is unusual in organic dystonia outside of specific genetic causes. And a rapid onset fixed dystonia following minor trauma can be a clinical red flag for functional neurological disorder. Tremor distraction, so that's where amplitude and frequency diminish with cognitive distraction tasks. That's also useful. And then one more thing about functional dystonia, it typically presents with a fixed posture, and it predictably would not respond to botulinum toxin. You won't also see the sensory tricks in a functional dystonia that you might in an organic dystonia. Functional myoclonus also exists, so this has variable amplitude, it's suppressible. There is evidence on EEG, this Barrett shaft potential, so it's a pre-movement cortical potential that can sometimes be recognized before the so-called myoclonic movement, which would be suspicious for a non-organic cause. Okay, so this is a patient whose permission I received to record and also cut his face out of this video that Dr. Piesh asked me to see at Jewish Hospital. It was a guy who came in with a pre-existing unspecified diagnosis of tremor, and he'd undergone some sort of cardiac procedure where I think he went on bypass and woke up and his tremor was worse. But it looked fishy to the team, and so they asked me to come look at this. And here is what we'll see. You can make a couple of observations there. So I'm asking him to just kind of tap his fingers, 1, 2, 3, 4. As you can see, that left hand's pretty still. Now we go back to doing nothing. And we start to try to entrain the right hand. It entrains a little bit, but not as much. Yeah. What you can't see in this video, there is no evidence of any kind of oral tremor. There is no evidence of any kind of tremor in his legs. There are various moments of toe tapping that change in frequency and change the amplitude. But to round things out, I had him do this. Does anybody know what we call this? So this is Archimedes spiral. This can be helpful in diagnosing or at least grading the severity of essential tremor. And so what you're seeing here is screen left is patient right and screen right is patient left. And I had him do the one in his right hand twice because it almost looks like it has some legitimacy to it. I don't know. What do you think, Dr. Holliday? Yeah, that's true. Well, okay. I thought that there might have been something real there. It wasn't so much a disagreement, just as like I wanted to make sure that I wasn't like missing something in this guy. And so glad to know that it wasn't anything that we would need to medicate him more for. It's clear. Yes. Yeah. No, no. Um, so the key takeaway for people on Zoom is that tremors should really only have one axis, and this could be observable on an Archimedes spiral test. But I would say here, this principle was used to just illustrate that people with functional neurological disorder can still have an underlying illness. And so I think it's important that you assess for that like you would anybody that comes in your clinic. Yeah, do the whole thing. He was already on a bunch of primidone and another beta blocker, so it was suspicious to begin with. So functional gait disorder. I'm not sure how many of us see this. We tend to not take our patients out of their hospital beds when they come in, but maybe we should because I think this is really something that illustrates an important principle. People will often come in and say they feel ataxic or off balance, they can't walk, they're falling all the time, um, or that they can only walk or move in certain patterns or when they do a certain thing. And so you can see certain things with these gaits that are consistent. There is a gait that is this non-physiologic contraction of both antagonistic and agonistic muscles that is um, not suggestive of an underlying illness. And then astasia abasia is one that I think that probably illustrates a really the most important point here is that these people come in and they say that they have a problem with coordination, but what you'll see when they get up is they have a really ugly walk and it looks like that they're going to fall and it really scares nurses and hospital staff when you get them up and move them around, but they won't fall. And it takes a really, really high degree of coordination to maintain a balance like that. It's not a conscious thing that they're doing, but it does show us that the cerebellum, or at least a lot of their brain, is still intact, and we should look at this maybe in a different way. Um, so PNES, I think this is one that we hear about the most, and interdisciplinarily we deal with the most with psychiatry, with ED, um, and it's treated a little bit differently because this is a nuanced thing, and there are seizures that look like the semiology of PNES that leads us to believe that it's functional. But we'll talk a little bit about some signs here that would point you away from thinking maybe somebody has had an epileptic event and more so towards a psychogenic or a non-epileptic event. So eye closure is really, really specific for non-epileptic events. And so this is one of the things that as a new resident will be burned into your brain here. What are the eyes doing? Are they open or are they closed when the seizure happens? Generally speaking, a seizure should self-resolve within 2 minutes. Uh, and it's always a little bit sketchy to me to hear about a patient that comes in and they've seized for 3 hours. Like, how are they alive? And so I think that that's an important question to ask. You'll see non-epileptic seizures kind of tend around that 5 minute mark, more so than something around two. Um, Something that I think we all know as neurologists, but maybe other colleagues haven't heard before. When somebody has a generalized seizure, you don't expect them to have preserved awareness. This isn't always 100% true, but the vast majority of the time, somebody who you hear about that has generalized tonic-clonic activity from the ED should not be able to tell you anything about it. They should not have a rapid recovery. And I want to point out one thing here where it says ictal crying. This is actually a legitimate sign that does happen in epileptic seizures. This was a typo by me. So an ictal cry is something that you might hear at the onset of a seizure resulting from like the contraction of the diaphragm and the escape of air. But ictal crying in a non-epileptic sense is what we would think of as like a post-seizure crying spell. This can point to a non-epileptic etiology. As can things like pelvic thrusting, back arching, side-to-side head movement. The best thing that we can do for this is get it on EEG, which is why EMUs exist. Um, and I'd also like to point out that there's something to be said for somebody that comes in on an increasing number of medications at higher doses, and maybe even seems like they seize more when they get more medications. But every EEG we have for hours and hours and hours at a time has always only ever been normal. Um, that should make you ask some questions. Dr. Brown. I would agree with you. So for those on Zoom that didn't hear, Dr. Brown pointed out that maybe we should be a little bit more specific with our wording here regarding eye closure. Um, People have eyes closed in non-convulsive status, so what we're really looking for would be forced or maintained eye closure during a seizure event that is resistant to you trying to open their eye. So these are some clinical observations that you might see that could differentiate non-epileptic and epileptic events. Um, I want to point out here that urinary incontinence is often talked about as a really specific thing for epileptic seizures, but this can happen in both. And so that shouldn't carry a whole lot of weight for you. Um, this is kind of the level of confidence or a chart of the level of confidence that we can have in the data that we get on these patients. And what you'll see here is that there's at least a little bit of utility in a routine EEG being normal in these patients. You would expect that if somebody has epilepsy, there should be at least spark of a seizure or a slowing in an area if it's following a seizure. Um, Around that same level of evidence is a video of it. I think we'd all like to witness an event in person because you can test for things specifically. But we know that the best thing that we can have is somebody that is trained in the management of seizures, is familiar with non-epileptic seizures, is directly caring for the patient, has them on EEG, captures an event, is able to determine that there's not a seizure. So these I thought were some interesting observations about what might differ in an interview from an epileptic and a non-epileptic patient. My impression of this is that some of the data that you get from people that have non-epileptic events, and this does seem to be true, it's a little more vague. It's a lot more of I can't remember anything and less of trying to piece together details. And this is a schematic diagram that's a theoretical representation of maybe how PNES originates in somebody's mind and then progresses and ultimately can sustain itself. So sensory FND is one that maybe doesn't sound easy to parse out, and it's not necessarily because it does require a good understanding of how our nerves work. So things you should be looking for when somebody comes in with a sensory disturbance, does it follow a dermatomal pattern? If it doesn't follow a dermatomal pattern, then they don't have a stroke. It becomes hard to explain why somebody's having that sensory loss. That is, of course, unless it's in a symmetric pattern like stocking and glove. It would be rare for that to be really acute. Maybe in something like Guillain-Barré, it could progress over the course of days, but that would be unlikely. I wanted to point out here one sign that we use to support a diagnosis of FND, which is called splitting the tuning fork. So vibratory sensation travels through bone. So what you can do is get a tuning fork, you can place it on a patient's forehead, and it should feel the same on both sides because there's only one bone in your forehead. But if you have somebody that comes in with asymmetric or hemisensory loss, what you might observe is that on the unaffected side of the face, there is no sensory loss, but when you move it over to the left, they can't feel the vibration. This is not consistent with neurophysiology. Symptoms varying with distraction or reassurance. This would support something like functional neurological disorder. If you happen to see somebody in a non-epileptic episode, you can talk them out of it, and if they respond to that, there you go. Functional hearing loss, I think there could be some interesting ways to test this, like different objects you could drop when you walk in a room or maybe try to startle a patient. But there are more objective measurements that we have to confirm that hearing loss could be functional. Okay, so I think it's important that we at least try to think about what's going on in a neurobiological sense here. So the predictive coding model, this is a neurobiologically coherent account of why FND symptoms are real and why they can't be voluntarily suppressed. So the brain is not receiving false input, it's generating the symptom itself based on a maladaptive prediction that has been fostered over the course of time. It also tells us why things like physical therapy and psychotherapy work. We don't send somebody with functional weakness to a physical therapist to make the leg stronger. We send them to somebody who's specialized in functional neurological disorders that tells them how to work around the deficit that they're having, awareness of the pattern that they're falling into, and then alternative ways to navigate their life. Um, so attention and network connectivity play a big part in this as well. Um, Neuroimaging studies, they've found things that have tended to be fairly consistent. There is abnormal self-focused attention to the affected body part that will amplify symptom expression. Resting state fMRI has showed that altered connectivity in our default mode network and salience network can be observed in individuals with functional neurological disorder. When a symptom is being provoked, there is a hyperactivation of the insula and the anterior cingulate gyrus. We see reduced connectivity between the motor cortex and the supplementary motor area. And that's the region of our brain that's responsible for planning and initiating voluntary movement. These have been replicated across multiple independent international research groups, which does strengthen our confidence in this neurological basis of FND. So emotional stress can trigger or worsen FND symptoms in some patients, but it's not a required cause. And many patients will come in and they have at least no observable trauma history. You might learn something down the line, but it's not necessary for them to have functional neurological disorder. The limbic motor model explains a vulnerability, not a universal mechanism here. Heightened amygdala reactivity will disrupt the motor circuit through limbic motor connections. And this disconnection plays in with emotional dysregulation to create a neurobiological vulnerability in the patient. It's so adverse life events and chronic stress increase neurobiological vulnerability, and autonomic dysregulation is commonly associated with this. It explains why FND emerges in the context of stress or trauma, but also why patients have no identifiable psychological precipitant. Um, Perpetuating factors are the most clinically actionable things that we can treat a patient for. So what this looks like is having a patient gain a better understanding of what their triggers are and being able to understand that in that moment, what the basis of their reality is or what they're experiencing, and equip them with like the knowledge that this can improve and it will. And um, I think this is the basis of how we have to approach these patients. There's not a medicine that we can use. While we have some evidence about how these things are connected and interplay with each other, there's not anything we can directly do to it yet. Clinical assessment for these patients is no different than any other neurological assessment. You would keep an eye out for positive signs. Usually you'll gain a suspicion for this as you continue along your neurological exam. Um, and then if you start to get a hint of FND, I would say that it's pretty important to take a more detailed, I put psychiatric query here because a psychiatric assessment is a little bit more detailed than we are used to performing, and really nail down that history and see what you can find. There's data that shows that 50 to 80% of these individuals have depression and anxiety, but I kind of believe that it's probably closer to 100. And that these studies were self-reported. And so what happens in a lot of these individuals is their incorrect response to emotional trauma will sometimes lead them to have a poor recognition of emotional problems or psychological triggers in their life at that moment. And obviously, another great piece of evidence we can have is video of an event. So it's always important to ask family if they've gotten a video. If they haven't, make sure that they know too if it happens again. Collateral is good if a video is not available. guys. Refreshing, getting a frozen message over here. Okay, there we go. So I wanted to show you guys this case. Hope that we're not too far into it yet, or not spoiled it yet. Well, it's supposed to do one video and then go to another, but it's no. Oh yeah, good. Okay. Okay. So also for patient privacy, I've tried to keep his face out of this, but I want you to pay attention to his legs and tell me what you guys think about these movements. This was an older gentleman that came to our service with we were told abnormal movements that were occurring during sleep, not asleep here.
I don't feel my hands now. God dang it. Guess I'm gonna have a heart attack. Oh, Jesus Christ, quit.
We got EMS coming.
Quit. My hands are done. I can't feel my hands now. God, I hope it ain't that. Oh, God.
Okay, so not
Oh, man.
the best view there, but I hope that you guys are able to see what his legs are doing. Does anybody have any opinion about that, or what was your impression? Okay, agreed. Yeah, I don't know how to explain it, but I agree it is stereotyped. It is not myoclonic. Could it be a seizure? Right. Probably not a seizure. Could it be functional? It could all be functional. Everything could be functional. But let's give this guy a couple of days in the hospital and see what happens. Because you want to make sure that you're not missing red flags. And while a change in the character of a movement is not always a red flag, you should still ask why it's happening. So these are his legs several days later. So I would say that the movements that you saw initially, those were more subacute over the course of a couple of weeks, but the change from that to this in the hospital was within a week. Dr. Brown, what do you think about troubleshooting this one? Yeah, okay, so but that's not the total spoiler here. What I think is really amazing about this is the movements that you see here, they're bilateral triple flexion. This is under general anesthesia. He's like, this is in the operating room. Um, and it was both stimulus induced and spontaneous. Oh, yeah, yeah. Well, it was triple flexion. There are some other videos and you could see his hip flex, you can see his knee flex. Yeah. And so then his diagnosis ended up being a pretty severe cervical myelopathy. I know that we like to look at it on axial, but I think this is the most dramatic view and kind of illustrates the point the best. In the first video, no. And so the assumption would have to be that there had been a decompensation in his myelopathy, like leading to worse disability and continuing to worsen until he developed really kind of a almost permanent, really severe upper motor neuron sign. So I wanted to take just a couple of slides to point out that FND is different from malingering and factitious illness disorder. And I think this is important to note because we should maybe document that we have suspicions that somebody might have one of these. It's hard to say all the time if it's totally true. There are things that support a diagnosis of either factitious or malingering. But one thing that I think that we should do a better job of is not committing these people to an FND diagnosis. There are a lot of people that come into the hospital that are clearly factitious and they get this label of FND. And what that does is it gives the patient the wrong diagnosis. It is like miseducation of other providers who see this patient and now associate what they're doing with a neurological condition. And it perpetuates the cycle, right? So these people will continue to come to a neurology clinic for FND when they have factitious illness disorder. Um, so some features of factitious illness disorder that should make you suspicious. Patients that go to different hospitals with the same condition, patients that have a really high level of medical knowledge to the point where they use terms that some medical students might know. If a patient's symptoms happen when you walk in the room and don't when you're not in there, there's a strong chance that's factitious. This happens all the time. We've seen this on EEG. We had a lady come up that really looked severe and autoimmune encephalitis was in the differential. She had myoclonic movements and she couldn't do anything. She was totally disabled. But on EEG, she didn't know she was on video and she was able to like use her phone and open ketchup packets and you'll see down here that the recommendation is not to confront patients about this, which I will say was true in that situation. We asked the woman how this could possibly be that she was able to use her phone and that we saw her have no symptoms. And she got really frustrated and she reported Dr. Schaefer and me. So malingering, this one is harder to prove unless you know that there is some secondary gain to be had. I don't want to stereotype prisoners, but that is the most common situation you'll see is people that are in jail and they will develop a symptom to not be in jail and come to the hospital. This can present in various ways. It could be stroke symptoms. It can be people that swallow objects over and over again. I know there's one guy in our ED who won't let his surgical scars heal. And so these people, they don't have any desire to be treated as a patient. They are disengaged in like physical exam and history taking, and they not unfrequently have evidence of antisocial personality disorder. So suggestibility and symptom induction, I think, are worth noting briefly in FND. This tends to be a fairly suggestible population, which can work for and against you. The suggestible nature of these individuals makes sometimes emotional burden a bigger trigger for them, but it also allows you the opportunity to encourage them and prime them with expectations that they can get better, that this is a diagnosis that we know how to treat, and that they're healthy, that structurally things look good. So you can frame things in a positive way that will allow this patient to leave feeling a little bit more secure about their diagnosis than they would if you weren't to just say it. So some clinical circumstances in which suggestibility can be demonstrated that we don't often do anymore. A tuning fork test here. So there is a situation in which you could be speaking over a patient as if you were talking to another individual and you say something to the effect of, I can induce a seizure with this tuning fork if I place it in this specific spot. And you place it there and they seize, and then you can do the same thing to stop it by saying, I put it on their toe and the seizure will stop. So it's interesting, but not necessarily ethical, although we do perform some variations of this, like hyperventilation. This is a big triggering maneuver for our psychogenic non-epileptic patients when they come to EMU. We don't do a lot of placebo. If I could pick one line from this whole presentation for you guys to take away, it's that the delivery of a diagnosis of FND is the therapy. And so the best thing that I think that you can do for a patient when you see them, even as early as like the first time you see them, if you have a suspicion that somebody has a functional condition, tell them. I mean, I think that's fine. I am going to rip this from Dr. Holliday. I heard you say this a couple of years ago. I know what this is because I've seen this before. I know how to treat it. And I think that's a reassuring thing for a patient to hear. And it's a lot different than saying, we can't find a cause. We're going to keep looking. And it gets more invasive. And it allows them to grasp onto this idea that there's something unfixable about them. So I will say to them something to the effect of, we need to make sure that there's not anything here that would be a danger to your life imminently. And usually we can do this by just getting an MRI. And then I'll also broach at that time. But if I'm going to be totally transparent with you, I think that your psychological health or some other sort of stressor could be playing a role in this right now. And there might be a little bit of them being taken aback. And so you should validate what they're feeling because that's not real. But then I think that maybe you dig a little bit deeper. You ask about their family, what's going on at home. What are some things that maybe you wouldn't traditionally ask somebody in an interview, but could be potentially stressful for somebody? Um, and I don't think it's wrong to kind of let them live in the patient role a little bit and don't try to minimize that their symptoms aren't real. They're really suffering, and I don't think it is good for them to come in and say, you should be able to move your leg. Like, there's no reason you can't move your leg. So don't try to invalidate the way they feel to prove a point to them. This is going to weaken the patient-doctor relationship. They're not going to respond to you in the future, and it can make things worse. And I think it is just as important as the way we talk to them to tell them like what the plan is for therapy. We know that physical therapy and CBT, they have evidence proven benefit for people with functional neurological disorder, and it's important that we tell them that there is hope to help with this condition. So no single treatment, though, is universally effective. I think it's a multidisciplinary approach. You need psychiatry, you need physical therapy, you need neurology. PM&R can be helpful, occupational therapy. And you need to make this diagnosis early and in a timely manner. The longer people are able to sit on something like with FND or lack of clarity, the worse it's going to be. So specialized physical therapy. So this is specific training for functional neurological disorder. You should make an effort to send these people to a physical therapist who's familiar with the condition. I know at Fraser, we did have a program where people were admitted inpatient, and we had a really strong option for these people here. And I think we still have the capability, maybe just not the formal program itself. There is evidence down here that you can see that this is helpful. I'm going to go through these a little bit more quickly because we're running low on time. Cognitive behavioral therapy. The strongest evidence that this works is in PNES patients, but the concept is the same. It involves working around these maladaptive beliefs and trying to reframe the way that your brain predicts the outcomes and what's happening. Pharmacotherapy, there's not a medicine for PNES. In fact, you should make an effort to pull people off of unnecessary medicines, particularly anti-seizure medicines. But I want to make a point here that if you have a patient that comes into the hospital with depression and anxiety, you don't have to be a psychiatrist to start Zoloft. That's not hard to do. You're not going to give them serotonin syndrome on a low dose. And you're going to give them some momentum that will carry them to a psychiatry appointment to say that this treatment has or hasn't worked. Maybe it started to kick in by the time they get there, and it allows the psychiatrist some data to work with when they're deciding what therapy is best. You should consider what the patient's disposition is in terms of what you'd pick. So if somebody is more anxious in a functional sense, an SSRI, if they tend to be a little bit more fatigued or even have some pain, SNRIs can be a good option as well. If they happen to smoke and want to quit, you could loop in Wellbutrin into that. These are all easy things to do. So emerging treatment for FND, TMS has caught on a little bit. We understand why it would work. We just don't have the data that shows it yet. Eye movement directed therapy has been shown to be helpful. Inpatient therapy is extremely beneficial. And I'm not saying that every patient that has FND should be sent to Fraser for a week, but if you have somebody that's really refractory, I think that this makes a big difference to the patients. Take them. All right. All right. The doors are open. So send them on over. You have Caitlin's permission. But there's a lot going on with this. And I think that we're going to be able to offer more to these patients as we understand it on a more neurobiological level. And also as more places are able to pick up their own initiatives and try different approaches with these patients. So prognosis and outcome predictors. Outcomes are guarded. You have a better chance of somebody making a recovery if they're a child. You have a better chance of somebody making a recovery if you diagnose them quickly. If the condition itself has been going on for a shorter period of time, and especially if there's a clear precipitant. If there's a big life event that precedes their illness, that's something you can work with, and that's something that you should emphasize when you talk to the patient. Relapse is common, and this is something that some patients, it's okay to tell them this. Let them know that, things might not always be steady, but we've got a plan and that we are going to manage. Comorbid disorders, so depression, anxiety. I think this is vastly underestimated. We see dissociative disorders, somatic symptom disorders, cluster B personality disorders, fibromyalgia, migraines, mast cell activation syndrome, POTS. I mean, everybody knows what this list looks like. It's not to say that these are causing each other, but perhaps comorbidities play into this maladaptive predictive pattern. Epilepsy is not uncommon in those with PNES. People will go on to develop non-epileptic events, possibly as a result of lack of agency. Chronic pain, fibromyalgia, like we just talked about. And then people that have MS tend to develop a lot of symptoms. Nico, what do you think about that? Well said. Ehlers-Danlos, mixed connective tissue disorder, POTS, these run together, and there is something to be said about um, a link between these and the mixed connective tissue disorders, and that's an area that is being actively researched as well. So pediatric FND, bullying, trouble at school can be a trigger, trouble at home. It's important that you get family buy-in here and family-centered psychotherapy. That can be helpful. Elderly patients in TBI. I want to qualify TBI here. This is not somebody that like got into a car wreck and can't perform their ADLs and IADLs. This is somebody that got a concussion, right? And so this is a good time to point out, as I think one of our neuropsychologists did at Grand Rounds, that you should set the stage for somebody with a concussion too, that symptoms will resolve within 6 months. Military and veteran populations are also one to be definitely kind of just in the know about. They carry a high risk of PTSD and then FND. So key clinical pearls before we wrap up. FND is a positive diagnosis, not a diagnosis of exclusion. As neurologists, psychiatrists, anybody who puts time into learning what these signs are and what they tell us physiologically should feel comfortable at least bringing this up as a possible diagnosis. Diagnostic delay causes harm. The sooner that you can get a patient intervention, the better. Specialized therapy are the strongest options that we have to treat patients. FND can exist with structural neurological disease, so it's always important to take changes in complaints seriously by patients before you attribute it to functional neurological disorder. And that will wrap it up. With that, does anybody have any questions? Yes, sir. Yeah, very well said. Thank you for the comment. I think that it's one thing to identify it, but then like, what are you going to do about it? And you've got to find a way to communicate it with the patient. And it's different strokes for different folks. Some people accept the diagnosis when you talk to them a different way. Any other thoughts, questions, Dr. Brown? I think it's there to stay. Right, right. And I think that, yeah. For those still on Zoom, we're having an interesting discussion about the proper semantics here. Sandy? That's a great question. So she asked, like, when is it okay or not okay to expand the workup again? So I think that if you can follow along like their clinical path with some of the same observations that you would have in the FND that you just diagnosed, you can make that diagnosis again without an extensive workup. So clinical patterns. I don't necessarily think that there is a point unless it's something you can find evidence of on exam. Nico?